Presenting a case of Mr. Seth, a 66-year-old milkman and a paper delivery man hailing from Mudbidri, who belongs to a socio-economic status lower middle class, according to modified Kupuswamy classification. He came with the chief complaints of a swelling in the left groin for 4 years and a swelling in the right groin for 4 months. History of present illness, patient complaints of swelling in the left groin. Surgery was done 4 years ago in the left groin for hernia, which was present since 8 years, but it recurred in 3 months after surgery when he started lifting heavier objects again. The recurrence was insidious in onset, gradually progressive. It started as a 2 into 2 centimeter swelling, and it has now progressed to 10 into 8 centimeter swelling over the last 4 years. The swelling increases on standing and on coughing, and it was initially reducible, but now it doesn't reduce on lying down and on manipulation. It was also associated with a dragging pain, which was insidious in onset, non-progressive, and it increased on coughing. Patient also complains of a swelling in the right groin, which was insidious in onset, gradually progressive over 4 months. Initially only appeared on lifting heavy objects, now appears as a 4 into 4 centimeter swelling. The swelling increases on lifting weights and on coughing and reduces on lying down. It was not associated with any pain. There's also a history of nocturia since about 6 months, for which he had to get up about 2 to 3 times at night. There's no history of cough, fever, trauma. There's also no history of narrowing of the urine stream, incomplete emptying of urine, post-void dribbling. There's no history of nausea, vomiting, abdominal distension, colic pain, constipation, diarrhea. He's also a known case of diabetes mellitus for 10 years. He takes medications regularly and is on oral agents. He does regular follow-up, and his blood sugar is under good control. He's also a known case of hypertension for 9 months. He takes medications regularly. Again, similarly, he also does good follow-up, and the blood pressure is well controlled. Past history, there's no tuberculosis, asthma, epilepsy. There's a history of surgery done for hernia in the left groin 4 years ago, but there's no other abdominal surgeries which was done. Treatment history, he's on medication for hypertension and diabetes mellitus, and there's no history of allergy to drugs in the past. Family history, there's no history of connective tissue disorders, hypertension, diabetes mellitus, or tuberculosis. Personal history, he consumes a mixed diet, he has good appetite, he has good adequate sleep, his bowel movements are normal, and bladder movements, he has nocturia. Habits, he has a history of alcohol consumption since the age of 18 to 20 years, and he consumes about 30 ml of whiskey every day, and there's no history of smoking. Summary, a 66-year-old milkman, known case of diabetes mellitus for 10 years and hypertensive for 9 months, present with complaints of gradual progressive swelling in the left inguinal region, which occurred 3 months after surgery, which was done 4 years ago. It increased in size with exertion, associated with dull aching pain, which aggravates on exertion. And he also has a gradually progressive swelling in the right inguinal region, which increases in size on exertion and relieves with rest. He also has nocturia. Probable diagnosis, bilateral groin hernia in which the left is recurrent.
So can you please tell me the relevance of the age and the hernia?
The type of hernia, like in older ages, since there's muscle weakness or there's like some other debilitating diseases, like so it causes this weakness of muscle. So direct hernia is more common, and in young, if it occurred in younger age groups, it's more likely to be a indirect hernia because of a patent processus vaginalis.
Very good. What about the gender?
Gender, in both males and females, the most common presenting hernia is the indirect inguinal hernia itself.
Very good. Very good. That's what I wanted to make it clear. Okay. The questions can be asked twisted this way. Okay. The most common hernia in men.
Indirect inguinal hernia.
Most common hernia in women.
Indirect inguinal hernia.
Femoral hernia is most common in
That's more commonly present in females than males. Like
That's
the ratio of
okay.
10:1.
So, females, inguinal hernia is more common, whereas femoral hernia is more common in females. Okay, don't get confused in that
Yes. Yes.
that thing. What about the
Yeah.
occupation?
Occupation, in case of heavy lifting, so it may increase abdominal pressure, so it could cause hernia. Or in case of like occupational diseases with chronic cough, again it could cause
Good.
abdominal wall weakness.
Good. Okay. So, what are the chief presenting complaints here?
Swelling in the left
groin for 4 years. Okay, and swelling in the right groin for 4 months. So, the left groin swelling was there for 8 years, and 4 years ago
Yeah.
he underwent a surgery. After which the after 3-4 months of the surgery, it got the swelling got reappeared. Right. That's the history, right?
Yes.
So we'll
Yes,
go
sir.
to the next slide. So in the for the other members, what we should note is in the chief complaints of any hernia case, we should write it in the 3 categories. First, the presenting complaints, like what he has written. Okay, about the hernia, about the swelling, you can write about the pain. Okay, this is the most commonly with which the hernia patients presents with. Secondly, there will be complaints about the complications of hernia, like Larry.
Complications of hernia, it could be
No, what are the
irreducible
chief
where it
complaints?
cannot.
Chief complaints. What will be the complaints with which a complicated hernia presents with?
It could, if there is obstruction, there could be abdominal distension, colicky pain, or even dragging kind of pain, or vomiting, diarrhea in case of Richter's hernia. There could be.
So, okay, these are the
If there's strangulation,
strangulated hernia. There could be toxic symptoms.
fever, pain, more pain, redness.
Good. In the third part, okay, this is the first about the hernia, second about the complications. In third part of the presenting complaints, you may write about the precipitating factors or the etiological factors. For example,
etiological factors again, like chronic cough, which can cause weakness, or abdominal swellings, which can again increase the pressure, causing weakness. Or
so in this way, you can categorize, okay, into three categories of presenting complaints. Okay, so next, coming to the history of presenting illness. The first slide. This is the first slide.
this is
Left surgery was done 4 years ago, for which for hernia which was present 8 years ago. Okay, recurred. So did you ask more about the surgery? What kind of surgery was done? Whether the mesh was used or not, or any post-operatively any infection was there? Or any hematoma or anything was formed? Okay, or within like immediately it's recurred, or after 3 months, exactly after 3 months. All these things in detail you could have asked. Did you ask anything?
Yeah, but he didn't exactly know which surgery which was performed. He just knew the region, and he knows that there's a scar there, and he didn't know exactly when. He just knows that when he started working again, it reappeared.
Okay. So, what are the causes for this recurrence of a hernia post-operatively?
Recurrence, it could be due to patient factors or like operative factors.
Okay.
Like during the operation. So patient factors could be like if the etiologic agent isn't treated,
Very
or
good.
if in case of old age, already weak muscles, and if he has a debilitating disease like diabetes, or if he is a smoker, then weak
Not
muscle
corrected
formation.
with the surgery.
Yeah.
Hypoproteinemia, anemia. Okay.
Yeah.
Okay.
Surgical was it?
Yeah. Next, surgeon's factor. One is patient factor. Next is surgeon factor. What are those?
Surgeon's factors could be like if the defect wasn't completely closed, or if mesh size was too small. Like usually the mesh contracts, so it should be like at least 5 centimeters from the defect, so that when it shrinks, it will cover it up. if the sac wasn't completely ligated, so that the hernia can again come through the sac, and if the mesh is like the heavier meshes are more likely to cause recurrence, and if the suturing to the structures isn't
Tension.
done properly, then again the mesh can get detached.
Too much of tension between the sutures.
Tension, yeah.
And you know,
Earlier,
Larry, what's the most important cause among all? In an elderly male, when an elderly male patient comes to you, okay, for a surgery, you tend to think that it's a direct hernia and just do the post-abdominal wall repair and close the defect. Okay, you don't go to check for the indirect sac. Okay, okay, and you usually miss that. So that's one of the most common. So they may have come both like direct as well as indirect component of the hernia. That's called pantaloons hernia. That's one of the most common cause of recurrence. Okay, and like other you told that tissue factors are there and technical factors like too much of tension and the other things. Okay, so we should keep it in mind. Which even in the elderly also we should make it a point to check for the indirect sac. Okay, in case of the hernia. Okay, next recurrence was insidious in onset. Okay, it may not be. It could be spontaneous. Okay, what are the modes of onset of hernia?
If there is a wound, hematoma which got infected.
No, in the beginning, in a normal hernia, what are the modes of onset? The congenital hernia, what is the mode of onset?
In hematoma, it will be insidious, but acute onset could be something like
congenital hernia. It spontaneously occurs, right? At birth, it will be spontaneously the hernia will be there because the patent processus vaginalis is there through which contents keep coming spontaneously. It is spontaneous. Yes. Like you said in maybe in direct hernia or in adults. Okay, it could be insidious. Okay, the hernia, slowly it will progress. The defect size become more and more, and slowly start the contents starts coming out. Okay, that's the insidious in onset. And the third variety is post surgery. Okay, that is trauma after any trauma. Okay, any after trauma, that is surgery is also kind of trauma only. So even after surgery, it can recur if it is not properly done. So three modes of onset are there. And one more thing, did you ask in the history where did the swelling appear first? Is that important?
Yes, like from the ring, like if it appeared from the deep ring, or is it like medial to the
no.
Like in the Hasselback's triangle?
Sorry, in the patient can tell whether whether it appeared from the scrotum and then developed to the groin region, or it started in the inguinal region, or then it went on to involve the scrotum. Is that important?
Yeah, varicocele or lymphovarix can go from the scrotum to the.
More than that, what you want to rule out mainly? This is the most other common groin swelling, scrotal swelling.
Ectopic testis also in case of congenital.
More than that, more commoner.
Hydrocele.
Very good. Hydrocele. That's how you distinguish in the history itself. Yeah. Okay, if the swelling arises from the scrotum first, and then it involves the inguinal region, then it is most probably, like you said, hydrocele, or it could be varicocele. Okay, the swelling is first started in the inguinal region, then involved the scrotum, then it could be most probably hernia. Okay, in the history itself, you can distinguish between hydrocele and hernia this way. Okay. Okay. So that's about the site of onset and mode of onset. Okay, that you should have included. Next. Okay, this is about the progression. Okay, so swelling increases on standing and coughing. These are the aggravating factors. Okay, and it could be on even straining also. Straining, what like constipation is there. Okay, patient is straining. Okay, some urethral stricture is something is that patient has to strain for passing urine. Okay, in BPH, and also this could be the again the precipitating factor or aggravating factors. Okay, and what is this? Swelling was initially reducible, but now doesn't reduce on lying down or manipulation. So which swellings reduce on lying down and which swelling reduces on manipulation?
The ones which have adhesions or incarcerated ones don't reduce. The ones
direct
with
hernias reduce spontaneously on lying
yeah,
down.
yeah,
Okay, whereas indirect hernias need manual some maneuver to be done. What is that called?
taxes.
Okay, okay. If you are doing that, if you are reducing it through a manual, then it's called taxis. Okay, or the patient himself reduces, manipulates the contents inside the abdominal cavity. Okay, that's mostly in case of indirect hernias. So see, all this why I'm telling you or stressing, because in the history itself you can get the clue what kind of hernia it is, whether it's a direct or indirect, whether it's in a hydrocele or hernia. Everything can be made out in history itself. You no need to do examination if you take a thorough history. Is it clear?
Yeah.
So next, associated with dragging type of pain. So why is that pain in hernia?
Dragging kind of pain could be, or dragging pain or sensation could be due to the pull of the mesentery to which the intestine is attached. So it could, if it's because of that, it's usually due to, if it occurs near the umbilicus. But if it is due to chronic adhesions, then it could be in the umbilical area itself. I mean, in the inguinal area itself.
Okay, that's one of the causes for pain. Another cause in the inguinal region. Suddenly, patient hernia was there for a long time, but now suddenly patient started getting pain, severe pain.
Either due to incarceration or strangulation.
No. It's mainly because of obstruction. You say obstruction. Okay, in obstruction later on there will be arrest of blood supply also. That's ischemia. So even the severe pain, the continuous polycky type of pain continues, and then suddenly pain stops. Why? Then what that refers to?
Okay.
See, there will be severe pain, and then after some time the pain stops.
Maybe
few days.
Reduced to.
After few days, there is obstructed hernia is there. There's a severe pain. Okay, for about 5, 6 days, 7 days, and suddenly after a few days the pain stops on its own, but there will be tenderness.
Maybe due to the hyperperistalsis, the obstruction got relieved.
No. Still, the hernia is there. That means the bowel has become gangrenous. The strangulation pain was there. Now the bowel has become all gangrenous and dead. So now it's not causing any pain. Okay, but there will be severe toxic symptoms and tenderness and other things. Okay, so if if the patient is complains, okay, I had severe pain, now pain has subsided, but still the patient is presenting with all the toxic symptoms, then you should always think of gangrenous bowels. It's a gangrenous contents. Okay, so I'm giving you hints in the history itself. Okay, so in your case now the hernia is non-reducible, right? Earlier it was reducible and now it's not reducible. So you mean to say it is a irreducible hernia, or it could be obstructed also?
Okay.
Because patient is having pain.
I couldn't hear, sir. Hello, I couldn't understand. I couldn't get this.
So now the patient is having irreducible or obstructed hernia in your case, right?
Yes, sir.
Okay, it could be either irreducible or even obstructed also, because patient is having pain. Okay, it could be obstructed also. So what are the causes for irreducible hernia and obstructed hernia?
Irreducible hernia is mainly it could be due to adhesions between the sac contents and the sac contents and the sac itself, or between the sac contents, or due to obstruction. Irreducible is also seen in case of both the obstruction and strangulated hernias, or if in case of narrow neck, very narrow neck. So
crowding of the contents because of the narrow neck. Okay, the contents have come out, then there is a crowding of content, they are not able to go inside again. Okay, this also cause for again irreducibility, and also when the next further it develops into obstructed hernia. Okay, so next slide please. Okay, in the right groin also there is a similar swelling. Okay, but it's for the first time. Okay,
Yes.
here there is no pain or anything. Okay, next. There is history of nocturia. What that suggests? Nocturia.
It's storage symptoms of urinary tract. So it could be like BPH, or where the urine accumulates, but it's difficult to empty it out.
Okay. What else it could be, if not for the BPH?
Since he's also a diabetic, he could have like polyuria, which could also cause nocturia.
Polyuria. Okay. It's called polyuria. He keeps on passing urine. So it could be nocturia because of. So you should ask for other symptoms. Any obstructive symptoms or retention symptoms are there of BPH? You should ask. If that is there, BPH is confirmed history wise, or else it could be even the diabetes. Okay, diabetes mellitus. Okay, good. Next slide, please. Okay, please tell me the why did you ask for all these questions?
Cough, fever, and trauma. It mainly due to it to find out the etiology. Even the narrowing of stream, incomplete emptying, post-void dribbling. Cough and fever mainly cause, yes, since patient like India, TB is very common. So like if you had a history of fever and cough, it could be like it could be a etiological factor, since cough increase abdominal pressure. Trauma, it could either be like a differential for hematoma, or it could injure the nerves and the muscle, causing the weakness and cause direct hernia. Narrowing of urine, no narrowing of urine stream, incomplete emptying, post-void dribbling are mainly urgency symptoms and storage symptoms associated with BPH. So again, BPH, the patient has to strain more, and that could cause hernia again.
Very good.
The last history I took to rule out any complications of the hernia.
So very methodically you have asked the questions. Very good. First you have ruled out all the etiological. You wanted to know the etiological factors. So you ruled out one by one to know the what is the etiological factor. Then comes to the possible complications of hernia. Right. This nausea, vomiting, abdominal distension. See, what are the four cardinal features of obstructed hernia?
It's tense, it's irreducible.
No. Symptoms I'm asking.
Symptoms would be abdominal distension, colicky pain, constipation, and vomiting.
Yeah. Okay. What is obstipation?
Yeah, obstipation too. If both flatus and feces isn't passed.
So then, what are the features of strangulation?
Strangulation, the patient would be more toxic to like fever. There could be excess pain. There could be other general physical findings like tachycardia. The swelling itself could be red.
Tense and tender. It's classically termed as the swelling is tense. The skin is stretched and shiny. So tense and tender. Okay. And also patient, as I told you, patient would have had severe pain, but now suddenly pain would have been decreased or subsided. That history will be there. Okay. Next. Okay. Fine. Okay. Fine. Next. So comorbidities are is a diabetic and also hypertensive. Okay. But on medications which are controlled now. Okay. Next. Anything contributory in your case, hernia, diabetes and hypertension? Any correlation?
In case of like for preoperative and during anesthesia, so in case of diabetes mellitus, all the oral drugs like before surgery, it should be stopped, since during anesthesia there could be a high risk of hypoglycemia, and hypertension. It should be controlled, like it should be less than 180 by 110. And some medications like ACE inhibitors and ARBs are supposed to be stopped, since it can cause hypotension during anesthesia.
Wonderful, wonderful. Okay, and fluids of choice, everything varies depending on this comorbidities, and post-operatively also we need to control this. Otherwise, what will happen? Wound infection and all can occur. If the hypertensive intraoperative intraoperatively BP rises means then it can cause a lot of bleeding even in the immediate post-op also. Okay, so we need to control all these before doing the surgery. Okay, next. Okay, past history. Okay, you didn't ask the details of the surgery. Patient doesn't know. Okay, that's okay. What is this? No other abdominal surgeries. Why did you ask? Are you suspecting some incisional hernia here?
More likely to be nerve injuries during other surgeries like appendicectomy or inguinal surgery.
So what will happen? I didn't understand.
It could be incisional hernias and it could be like other surgeries where the nerve like ilioinguinal or iliohypogastric nerves are injured, which could cause weakness of the internal oblique and the transverse abdominis, causing direct hernia again.
Good, good, very good. This point we should keep in mind, especially the PGs who are doing the surgeries for the for the first times, especially during appendicectomy, gridiron incision. What we give, okay, in that there are high chances that we injure. Okay, in fact, the nerve lies little lateral to our gridiron incision. Okay, so while closing the abdominal layers, that muscles, we may take bite or we may involve the ilioinguinal and iliohypogastric nerves. So if you injure that before it enters or it supplies the internal oblique and the transverse abdominis muscle, then it may cause weakness of the muscles. More than that, the incision of the appendicectomy, what causes nerve injuries while putting the drain? We usually keep a drain after the surgery. Okay, for if any collection is there to come out. So during that is the area under which the nerves lie. So we should be very careful while putting the drains. Can you name some other surgeries which are done in that area which can cause, or even in the left side, which can cause hernia? Some other, because since you're answering everything, I would like to ask some difficult questions. On the left side, on the right side, also, what other structures you do surgeries?
Again, previous surgery for hernia also could be there, but that's unlikely because the nerve could be injured in the canal itself.
One more surgery, what you do is colostomy. Okay, in that area, right or left side, you do colostomies and ureterolithotomies. The big stone is there in the ureter. Nowadays, everything is endoscopically done, but earlier they used to do open surgery. So, in ureterolithotomies and lumbar sympathectomy, have you heard lumbar sympathectomy?
For pain in case of Buerger's disease.
So this from where this ilioinguinal iliohypogastric nerve arise from?
Ilioinguinal is T12 and L1 root, and iliohypogastric
done. It may injure these nerves and may cause muscle weakness. Okay, so these are the some other surgeries which you should know of. Okay, good. Next slide. Okay, fine. Next. Okay, families know what are the connective tissue disorders. Some name, can you name some common connective tissue disorders?
Common could be like SLE, rheumatoid arthritis, or Marfan's, Ehlers-Danlos, but very specific for hernia could be prune belly syndrome or Eagle-Barrett syndromes.
Wonderful, wonderful. Okay, next, okay, hypertension, diabetes, tuberculosis. Okay, what other thing can cause this? Anything can run familially, hernia?
Anything?
Hernia. Any other reason which can run? The hernia can be hereditary or familial.
Any muscle defects which are inherited, like
any cause of muscle weakness. Okay, it could be connective tissue, so collagen deficiency. And the collagen deficiency also can be sometimes hereditary. Okay, all this can cause like familial hernia. Okay, causes for hernia. Next. Okay, sleep. Okay, bladder movements. He has increased. Okay, fine, good. Next. So this alcohol, smoking, relation with hernia.
Smoking before surgery, at least 6 to 8 weeks, there should be like you shouldn't be smoking till then, and healing, it could prevent the collagen formation after surgery. So that could also prevent cause recurrence. And smoking can also lead to COPD. So chronic cough
Very
can.
good. So in two ways, hernia, smoking is related with hernia. Okay. One thing is this it can cause bronchitis and precipitate the hernia. Okay. Second thing is it retards this collagen formation. In that way also it can cause weakness of the muscles. And third thing is after operation it can cause retarded healing of the wound and all. Okay. So that way you need to, like you rightly said, you should ask the patient to stop well in advance smoking. Okay, good. Next.
Alcohol,
So, in that way, Larry, the most important part in hernia surgery is you should to treat the etiological cause first.
yes.
Okay, if anyone asks you how will you manage this case of hernia, first answer should be to manage the etiological agent. Okay, only then you will treat the hernia. Otherwise, the next day itself he can come with the recurrence. Okay, same thing happened within this fellow also. No, this patient also had underwent a hernia, but that straining factors he didn't stop immediately. That straining exercise was there, so immediately got recurred. Okay. So that need to be addressed. Next. Okay, now the summary. On the left side, he has a recurrent hernia, and on the right side, he has a newly formed hernia is there. Okay, so what do you think? What kind of hernia? Any clue from the history? No,
This
just a
one
groin
which
hernia.
reduces and
It's just a groin hernia, right?
Yeah.
Could be anything.
The one on the left doesn't reduce much, so it could be the indirect type, but examination has to be done. And the one on the right, like it's a small sized hernia, and it also like reduces easily, so it could be a direct one. But again, examination.
Very good, wonderful. Next. So let's move with the okay. You can also any etiological factors are there. You can include it here. Okay. Probable diagnosis bilateral groin hernia, left being the recurrent, correct, and most probably because of you can write some BPH or muscle weakness, whatever you want to include. You can write it here only. Okay, because etiology is mainly history wise. Okay. Okay. Next.
Can I start?
Yeah.
General physical examination, informed consent was taken. Patient's informed consent was taken. He was well exposed from the xiphoid to the mid thigh. The examination was done in a well-lit room. His privacy was maintained, and examination was done in supine and standing positions. The patient is alert, cooperative, well-oriented to time, place, and person. He is moderately built, well-nourished. His vitals, blood pressure is 140 over 86 millimeter of mercury, which was measured in the sitting position. Temperature is 37.5 degrees Celsius. Respiratory rate is 16 breaths per minute. Pulse, pulse rate is 70 per minute, which is a normal rate. His rhythm, the pulse rhythm was regular. It was normal in volume and character. The vessel wall wasn't felt. His height is 164 centimeter, weight is 68 kg, and his BMI comes to about 25.3 kg per meter square.
Is that important? BMI?
Yes, sir. Overweight can again be a cause of it can be an etiological factor for hernia.
Okay, obesity can also be a precipitating factor. Okay, good. Next. Fine.
There's no pallor, icterus, cyanosis, clubbing, koilonychia, lymphadenopathy, pedal edema. On head-to-toe examination, the oral cavity had good oral hygiene. The neck seems normal, spine and chest appears to be normal, limbs appear to be normal, and the skin again seems to be normal. On local examination of the left groin, on inspection, a solitary swelling of the left inguinal region, which is pyriform in shape, measuring about 12 into 8 into 3 centimeters. All its borders are well made out. It is present above and medial to the pubic tubercle, extending from the midpoint, mid-inguinal point to the root of the scrotum, and the surface appears smooth. Scar from the previous surgery is seen over the swelling. There's no visible peristalsis over the swelling, and the swelling doesn't reduce on lying down, and an expansile cough impulse is seen. On palpation, there's no local rise of temperature, no tenderness. All the inspectory findings are confirmed by palpation. The expansile cough impulse is felt. The swelling is doughy in consistency, and it's not reducible. It's possible to get over the swelling, and the deep ring occlusion test, semen test, and ring invagination test was not done since the swelling wasn't reducible. On percussion, a dull note was heard, and on auscultation, no bowel sounds were heard. Examination of the right groin, on inspection, a solitary swelling of the right inguinal region, which is globular in shape, measuring about 4 into 4 into 2 centimeters. Its borders are well made out. It's present above and medial to the pubic tubercle. Lateral extent is 4 centimeter lateral. It appears to be 4 centimeter lateral to the pubic tubercle and 4 centimeters above the pubic tubercle. The surface appears to be smooth, and the skin over the swelling is normal. There's no visible peristalsis over the swelling. The swelling reduces completely on lying down, and the expansile cough impulse is seen. On palpation, there's no local rise of temperature, no tenderness. All inspectory findings are confirmed by palpation. Expansile cough impulse is felt, and the swelling is soft and elastic in consistency and is reducible. It's possible to get over the swelling. The deep ring occlusion test, when the deep ring occlusion test was done, the swelling appeared medial to the occluding finger. And on Siemens test, the impulse was felt on the middle finger. And ring invagination test wasn't done due to pain to the patient. Percussion, a dull note is heard, and on auscultation, no bowel sounds were heard. On examination of the external genitalia, there's no deviation of the penis. Testes are palpable and normal on both sides. The scrotal skin is normal. The spermatic cord is normal. No urethral strictures felt. No narrowing of the urethral meatus. And the examination of the inguinal lymph nodes was normal. Per-rectal examination wasn't done. Systemic examination, on per-abdominal examination, the abdomen was soft, non-tender. There is no mass felt, no organomegaly. The tone of the abdominal wall is normal, and there are no signs of free fluid in the abdomen. Cardiovascular system, S1, S2 heard,
Good.
no
Next
murmurs.
slide. Next slide. That's it.
Next slide. Respiratory system, normal vesicular breath sounds heard bilaterally. Central nervous system examination, no focal neurological deficits. Motor and sensory examination is normal. Summary of examination: the left inguinal swelling is a piriform swelling with the positive cough impulse. It has a doughy consistency, present above and medial to the pubic tubercle, and is irreducible. And the right inguinal swelling is globular in shape with a positive cough impulse, soft elastic in consistency, and is present above and medial to the pubic tubercle. And on deep ring occlusion test, a swelling appears on cuffing, and semen test, the pulsation was felt on the middle finger. Provisional diagnosis: the patient has a left-sided inguinal hernia, which is of indirect type, incomplete, irreducible, with the omentum being its most probable content. And EHS grade could be RLX. He also has a right-sided inguinal hernia, which is a direct type, reducible, with the omentum being its most probable content, and EHS grade being PM2. And he also probably could have a benign prostatic hyperplasia too. Yeah.
Very good presentation. Very good examination. Okay, nicely done. So let's go back to the examination first slide. Okay, local examination here. Local examinations. Okay. So the shape itself can give you a clue, right?
Yes, sir. In case of indirect hernia, it's usually piriform. At the location of the deep ring, it's very narrow. As it goes toward the scrotum, it increases in size. So it's either pyriform or oval. So yeah, the distal end is more wider.
Yeah.
And in case of direct hernia, since it comes directly through the abdominal wall, it's more likely to be a globular swelling. And in case of other groin hernia, could be a femoral hernia, which is retort shaped.
Good. So, okay. Extending from mid-inguinal point to the root of the scrotum. Okay, fine. Left side is till the root of the scrotum. Fine. So it's an incomplete type of hernia, right?
Yes.
Surface is smooth. That means
it's like there's no incarceration or strangulation. Like it's not tense or.
okay. More likely to infer the underlying content. Okay, that in inflammation, that this thing and all, you will tell a comment about the skin or the swelling, not the surface. Okay, surface means whether it's a regular or uneven surface. Okay, maybe okay, but in here it's very difficult. Even the momentum also on inspection it's very difficult, but on palpation you can make out if it's smooth. The surface is there, then most probably it has a intestine as the content. Okay, whereas if it is some nodular kind, you can palpate. Okay, bosselated, this thing surface is there, then most probably it is a momentum. Okay, that's the inference. Next. Okay, so the expansal cuff impulse is seen, so that means it's not obstructed still, right? It's a it's a irreducible hernia, but not
But without any
obstructed.
obstruction.
Okay, in obstructed or strangulated hernia you will not get cuff impulse.
Expansion.
Okay, where else you get this expansal cuff impulse?
In case of okay, in the body or just in
the groin first you tell.
Expansal cough impulse could be seen in case of
expansal cough
varicose.
impulse. Expansal cough impulse in groin.
It could be a cephanovarics or
very good, very good. Okay, very good. So other type is other type of cough impulse is
thrill.
Where you can feel
thrill could be in case of varicocele or a lymphovarix.
Very good. Okay. Okay, fine. So next. Okay. Okay, doughy consistency. That's suggestive of.
It's suggestive of momentum, but still it could there's still a chance of it being intestine too.
How? What is there along with the mesentery? Sorry, what is there along with the intestine?
Intestine also has the mesentery. So
okay, mesentery also you might be feeling. That's why you may get that falls even in the intestine. It could be feel doughy. Okay. Okay. Swelling is non-reducible. Okay, fine. Next slide. So here it's not possible to get over the swelling. Okay, deep ring was not done. Can you please tell what are the deep ring occlusion? How to do deep ring occlusion test?
If the patient is if the swelling is reducible, we make the patient lie down. We find the deep ring based on the mid inguinal point at 1.25 centimeter above the mid inguinal point. We occlude it horizontally with our thumb or slightly obliquely, since that's how the opening of the deep ring is. Then we make the patient stand and ask him to cough. If we feel the pulsation on our thumb, then it's suggestive of an indirect hernia. And or if the swelling appears medial to the thumb, then it could be a direct hernia.
So what are the fallacies of this deep ring occlusion test?
One, it could be a wide ring which allows the even the.
You can't. Okay, very good, very good. Come on, continue.
And also, if in case of pantaloons hernia, both could be seen. So, like we can tell which isn't.
Nice. These are the two fallacies. One is pantaloons hernia. Second thing is very wide ring, which you cannot occlude completely with your thumb finger. Some through either medially or laterally, the contents come out. Okay, so it gives a medially usually it gives a false impression that it is a direct hernia. Okay, even though it's an indirect hernia. So these are the fallacies of deep ring occlusion test. But this is the most specific test. Okay, among all, this is the most specific test. Okay, okay. Then what's the Siemens test?
Siemens test is to know if it's a direct, indirect, or a femoral hernia. If in this case it's the left groin, left hernia, so we use our left hand, and from the left side, we go to the left hand side of the patient using our left hand, and using the three fingers. We occlude each of the openings. With the index finger, we occlude the indirect ring, again 1.25 centimeter above the mid-inguinal point. And with our middle finger, we occlude the superficial ring, which is above the pubic tubercle. And with our ring finger, we occlude the saphenous opening, femoral ring, saphenous opening, which is 3.5 centimeter inferior and lateral to the pubic tubercle. And this was done in lying down position. Now we make the patient stand up again and ask him to cough, and we try to feel the pulsations, where we feel the pulsations. If we felt it in the index finger, it's likely to be a indirect hernia. If it was
index,
on the middle finger and direct,
middle, direct, femoral, ring finger. Okay, ring finger, femoral. So easy to remember. I for I, D for D, R for R. Okay. What about the ring invagination test? Nowadays, we don't do this test. Okay. No more it's advised to do, because it's very painful for the patient. Okay. So either if you just mention the name, it's enough. Okay. Need not do in all the patients. It's a very elderly, uncooperative, need not do. Okay. So since all this can be the thing, what we should know here is all these tests can be done only if the hernia is reducible. Only then, that is the most utmost prerequisite for this test to be done. Or if the hernia is reducible, then we can do these three tests. Okay, otherwise not. So next. Okay, percussion is dull. That's again suggestive of some momentum being the content, and auscultation. Okay, okay, fine. Next. Here, what you have written, go to the next slide. Okay, next slide. You had written, as I noticed, getting above the swelling is possible, you had written.
Yeah.
Yeah?
Yes, sir.
How can it be? Then next slide, I think. Yeah, possible to get over the swelling. How can it be?
Since it hasn't descended into the scrotum, so if when we approximate the root of the scrotum,
you are doing get above the swelling, not get over the actually get above the swelling. That's only for scrotal and okay. So if it's palpable, if there is any scrotal swelling, only this inguinal scrotal or scrotal swelling, then only you tell it is a get over swelling is positive or not. Okay, in this case, it's not okay. Need not be telling this. Okay, because then it could be either only inguinal swelling, but it's not. It's only inguinal. It's not coming just to even the root of the scrotum also. You told no, it's coming till the root of the scrotum something.
Yeah, like just up to the root of the scrotum.
Okay. Maybe because it's a direct hernia. So direct hernias are most commonly incomplete. Even that too, very small hernias, maybe just inguinal hernias. In that case, you need not do this get above the swelling test. Get above the swelling, not get over the swelling. Okay. Get above the swelling is mainly done for scrotal swelling and to differentiate between inguinal scrotal swelling. If it's purely inguinal swelling, then no need to do this test. Okay. Clear? Okay. Deep ring occlusion. Okay, fine. So this appears like it's a direct hernia. Next. Okay, next. Yeah, in these small hernias, this is advice from my side. If it's a direct hernia, which is very small, like 3 into 3 centimeters, then you can't do this percussion and auscultation and all really, okay, because you don't know what's the underlying content. So if you don't do also in such small hernias, if you don't do this percussion and auscultation also, it is what is that justifiable. Okay, next. Okay, this is very important in case of a hernia. It's not just the hernia. If one-sided hernia is there, we must look the other side also, other side of the inguinal region also. Here, since it is bilateral, we have examined the both sides, and after the both inguinal regions, it's a must to examine the external genitalia. So, what all you look for in penis?
One is if there's a large swelling, it could cause deviation. And other things are like the meatus, we look for any narrowing. So,
3Ps.
Penis.
3P.
Try to feel
in penis. One is phimosis.
Paraphimosis.
No, not paraphimosis. Phimosis, because it causes the again narrow stream of the urine. Urine will be difficult. Straining is required. So phimosis. These are all the precipitating factors. That's why. Okay, you should mainly look for any phimosis is there. Second thing, any penile stricture, penile urethral stricture is there. Okay, and another P is
I don't know.
Pinpoint meatus, pinhole meatus.
Pinhole meatus.
Pinhole meatus. So phimosis, pinhole meatus, and third thing is
penile stricture.
Penile, okay, penile strictures. So all these three things you look for in the penis. Then comes the okay spermatic cord. Okay. Okay. Urethral strictures. No, how will you look for urethral stricture?
Palpating the one way is to palpating the ventral surface of the penis to find for any thickening. Or through the base of the scrotum, we try to feel for the
which part of the urethra?
Bulbar urethra.
Very good.
Bulbar urethra. Bulbar.
Very good. Okay. So mainly the base of the scrotum. There look for the bulbar urethra where any thickening is there, or sudden dip you can feel. Okay, sudden dip, that is suggestive of stricture again. Then you also have to look for the lymph nodes, regional lymph nodes. Okay, good. Next. Okay. What are the you have for UGs? It's not required to do, but you definitely you have to mention. Okay, you have not done. That doesn't mean that you should it's exempted. No, nothing like that. Ideally, you should be doing this. If not, at least you should mention. Okay, per rectal examination, your patient you should mention, and then just tell that because of lack of privacy or this thing, patient could not be done. Okay, so actually, what will you look for? What is the aim of doing per rectal examination in case of hernia?
One, we check for the rectum and the prostate. Rectum, we check for the mucosa or any strictures, and in case of the prostate, we look for enlargement of the prostate in case of benign prostatic hyperplasia. And
then anything else? Two more things. One is any mass in an elderly patient, even a rectal mass. Okay, growth could be there. And other thing is you will also look for on inspection itself. Look for any chronic fissure is there. Why?
It's a contraindication for.
No, not that. Okay, it's a contraint agreed. Other thing is it's a also give you the etiological factor could be constipation. Because of chronic constipation, they develop this fissure, right? Okay. So okay. Yeah. So if any, what's the sign of chronic fissure?
Sentinel tag and.
Very good. There could be a sentinel tag or sentinel piles. Okay, skin tag. Okay, that suggests you of chronic fissure. Okay, so look for all these four things. Okay, one is any chronic signs of chronic fissure, any mass. Okay, third thing is any the bulging of the prostate. Okay, and the fourth thing is
chronic fissures.
Okay, so that's about the per rectal examination. Next. Systemic examination. Per abdominal, why did you do the per abdominal examination?
Intra-abdominal masses or any fluid like ascites could
increase the abdominal pressure.
Mass effect. Yeah.
And another thing,
Tone, like even the abdominal muscle tone. So if it's weak, then it could be a cause
How do
for
we
direct,
assess?
or it could.
How do we assess?
Huh?
How do we assess the
Which
tone
one?
of the abdominal wall?
Two ways. One, we look at the lateral profile and see for any excess protrusion of the lower part of the abdomen, like below the umbilicus and above the pubis. And other thing is, we make the patient lie down and raise his head and check for any appearance of the malgagnes bulges on the flanks of the patient, which indicates weakness and needs hernioplasty most of the times.
Okay. So, what are the cardinal signs of a hernia?
An expansile cough impulse and reducibility.
Reducibility. If these two things are there, then it is a hernia only. If it's not there, also still it could be hernia. Understood? Okay.
Yes.
So, if the patient is unable to cough, how you will elicit hernia? Your patient is not able to cough. What will you do?
Valsalva, like.
Very
and
good.
in case of babies, we make them cry.
Yeah.
Increases pressure.
Okay. So that's another way. Okay. Or else, yeah, like you said, even you can ask the patient to lift the leg. Okay, lift the leg. In that also, it's a straining. In that time also, the hernia may come out. Okay, next. Okay, mainly this is systemic examination. Mainly again to look for respiratory system and all. Mainly to look for any etiological factors like any COPD, TB, anything is there. Okay, good. Next. Okay, now what's the final diagnosis? The left side is the go to the now. So any hernia diagnosis should be written under six headings. Okay, so first either read right side or left side. Okay, next it is inguinal or femoral. Okay, inguinal femoral. Then third thing is direct. If it's inguinal, then it's direct or indirect type. Okay, then comes if it's a indirect type, then it's a complete or incomplete. Okay, direct is very rarely it will be complete. Okay, most of them it's incomplete only. So 4 points. Fifth, it is complicated or non-complicated. Okay, complicated means like this irreducibility is again a complication. Irreducibility, obstruction, strangulation, incarceration. So anything is there. Or non-complicated, it's a reducible hernia. You can write. This is the 5th point. 6th is the most probable content. Okay, so under these 6 headings, you should write any hernia diagnosis. Okay, don't miss out. What is this EHS classification? What you have mentioned?
It's the followed classifications grading of hernia. So European Hernia Society grading. So it has 3 parts to it. The first part is if it is primary or if it is recurrent. In this case, it was recurrent. So R. If it is primary, it would have been a P. And the second part of it is it could be 3 options, either an F or an L or an M. F indicates femoral hernia. L, since indirect starts coming from the lateral side, it's L. And since the direct hernia comes through the Hasselbalch's triangle, it would be denoted an M. And the third part, it's a number, either 1, 2, 3, or X. It denotes the size of the defect through which the hernia comes through. So if it was 1, it means that the defect is less than 1.5 centimeter. If it is 2, it would have been less than 3 centimeters, and if it is 3, it would have been more than 3 centimeters. Here it's X because since the swelling wasn't reducible, we couldn't make out the size of the defect. So
wonderful.
We couldn't identify.
So remember, there are 1, 2, 3 doesn't indicate the centimeter. Okay, in fact, it is 1 is 1 finger breadth, 2 is 2 finger breadth. So 1 finger is approximately 1.5 centimeter. It's considered. So 1 is less than 1.5 centimeter, 2 is 3 centimeter, and 3 fingers is more than 3 centimeter. Anything. Okay, so that's the that's what indicated by 1, 2, 3. So next slide. So again, the right side also, he has written under 6 headings: right-sided, inguinal, direct type, and and it's incomplete. No, direct, incomplete. You should have written.
Yeah, no,
Okay.
I haven't.
Yes.
Yeah.
And it is reducible, and momentum being the probable content. Very good. What is PM2? Again, please explain for the benefit of our members, and it will be a revision.
Here it's a primary. Since it occurred for the first time, there it was a recurrent one, and here it comes the swelling comes more medially, like just above the pubic tubercle. So probably a direct. Since we thought it's a direct, so we say M medially, and if you could incorporate 2 fingers into the defect, and since it was reducible, we could try to insert the fingers into the defect. So 2.
Okay. So what are the features suggestive of benign BPH here? Only nocturia was there, no? Nothing else.
Yes, only
Okay.
only nocturia.
So fine. So anything else? Next slide. So this is the direct and in. Okay, fine. So this is your case. Okay. So bilateral hernia. You did open hernia repair here.
Yeah. Yes, sir. Lichtenstein's.
Okay. Why did you do? Okay. Why did you do? So why did you open it? Why not laparoscopic?
Since it was a recurrent one, there's high chances that there could be adhesions in the sac, and which is more difficult to remove during laparoscopic surgeries.
What are the indications for laparoscopic hernia repair?
Indications are bilateral and recurrent. So here, yeah, it was again bilateral and recurrence is.
So you could have done laparoscopic, but since it was irreducible, the left side one was irreducible. Okay, it's not easily reducible. So you expect some lot of adhesions and contents also crowding. So it's like you said, it's very difficult from inside to pull the contents. So it's better to go for open repair instead of converting later. Okay. Okay. So you want any other slides? No. Now
No,
we'll ask some questions. Go back. Any other hernia classifications you know? Than EHS?
One is and Gilbert classification.
Okay. Gilbert's is old. Now we don't use it, but you should know 2 classifications, 3 classifications you should know in hernia. One is Gilbert's. Second thing is NIHAS. You know NIHAS at least? NIHAS, can you tell?
There are 4 categories in case of NIHAS. Category 1 is indirect with the deep ring intact. So it's a
Normal
congenital.
Normal
deep ring. Yeah. So it's likely to be a congenital hernia. 2 would be again an indirect hernia with the dilated posterior
deep ring.
Deep ring. Yeah. And 3 and 4. 3 is the 3A, 3B, and 3C again. 3C is femoral. 3B is pantaloons hernia. That's both the direct and indirect, and that is indirect with posterior wall weakness. And 3A is without posterior wall weakness. So just a direct hernia.
Direct.
And
so actually 3 refers to posterior wall defects only. 3 means posterior wall defect. 3A is direct, only direct. 3B is pantaloons. Okay. And 3C is that femoral hernia. Okay. And 4 means?
4 means recurrence or
recurrent hernias. Okay. So under which category your hernia belongs to?
In indirect type with incomplete irreducible. So let's say it could be 2A, 2 group 2.
No.
Recurrent one. So it's a 4.
4 only. In 4 it could be anything. Okay. Indirect, direct, or it's a type 4. You are okay. Type 4. You are right. Okay. But yeah, you can modify it as your type 4. Okay. What about the other side? On the right side?
It's a direct type without any like signs of an indirect involvement or femoral hernia. So it's a 3A.
Okay, good. 3A, fine. So at least NIHAS classification, Gilbert's, and EHS classification. EHS you must write in your case sheet also. Okay, good. So now how will you manage this case, Mr. Larry?
If it was a unilateral one, it's usually a lichen
No. I asked how will you manage this case?
Okay, manage investigations first, like specific investigations for this case. If needed, an ultrasound could be done, or in ultrasound again, since we are suspecting BPH, we could just check the post-residual volume and the size of the prostate itself, and any free fluid, even ascites or any peritoneal fluid. And before the surgery, again,
chest X-ray can be done.
Complete
rule out any. Chest X-ray can be done. Why?
Chest X-ray can be done for a TB or any COPD or chronic obstructive pulmonary disposing cough, etiological. Since you have to treat the etiology first, so.
So hernia is more of a clinical diagnosis. Okay, no need to do any investigation per se for hernia. But like you said, to rule out the etiological factors, you need to do some investigations like this. Okay. Okay, good. Then what treatment you will do for in your case? Elderly male, no, he's some 65-year-old. Okay, and having only BPH. Think that he is having BPH significant, some more than 100 ml residual urinary volume is there on USG. Okay, so and with recurrent left side hernia, and on right side there is a inguinal hernia is there. So what treatment we will do? Advise the patient.
If we had a BPH, then it's better to treat the BPH first. So transrectal resection of pelvis, transurethral resection of prostate. Sorry,
TURP. It's called TURP.
Could be done.
Transurethral resection of prostate. Okay. Then
once that's managed, then since if there's no other cause, if there's a TB, then maybe start ATT. But if there isn't, then treat the hernia itself next. So if it's
no,
a bilateral,
you can do it in the same sitting only. Okay, both the prostatectomy as well as the hernia surgery you can do in the same sitting. Anyway, you are going to give the spinal anesthesia for TURP. So in the same sitting, after doing the prostate surgery, simultaneously also you can do. Okay, one will be doing the TURP from below, and the surgeon will be doing a hernia on the other side. Okay, you can do the same sitting. Okay, so what do you think the best? On laparoscopic you could not do because it was irreducible. Any other surgery you do like can be done here?
For bilateral recurrence, even Stopa surgery.
Yeah, any bilateral inguinal hernias are there. Stopas can be done. What is Stopas repair?
In case of Stopas repair, infraumbilical incision is done, and we enter the preperitoneal space. Okay. And from the preperitoneal space, we can reach both the sides, and we place the mesh covering the defects. If it's a very small defect, then we don't need to staple it because Pascal's law. So, like if it's a small defect, so it will hold itself.
This is more physiological. Okay. This is just like laparoscopic, but you are approaching from anterior side. Okay, not from behind. Any preperitoneal mesh repair is the more physiological, like you said, Pascal's law. See, whenever there is a straining is there, the mesh will be pushed against the anterior abdominal wall, and there will be it will get fixed more and more the mesh. Whereas if you put it in the like we do in the hernioplasty from above the muscles, then when there's a straining factor is there, mesh will be pushed outside. Clear? So the laparoscopic or the Stopas is the more physiological way of correcting the hernias, okay, or repairing the hernia. So, but bit difficult one approach and all, and only it's and again a giant mesh is required. Again, may not be available in all centers and a bit costly. So even now we follow the classical or conventional. What is this surgery? What you did here?
Lichtenstein's tension-free
hernioplasty. So how we do that?
From the first part, it's the groin crease incision just above the groin, like the one on this side. And from there, we incise each layer. First the skin, then the campus fascia, scarpus fascia, then the external oblique is split. Then from there we reach the inguinal canal with the cord and the ilioinguinal. There we, if needed, we can reduce the sac and ligate it so to prevent the recurrence. That is it's herniatomy. And also, if there's a associated direct hernia, we could also do a herniorrhaphy at the same time. And for the main, since it's an older patient with abdominal wall weakness, to prevent both, we put a mesh covering both the defects. And
How do you do the herniorrhaphy?
Herniorrhaphy, the here we put a suture between the conjoint tendon and the inguinal, the medial deflection of the inguinal ligament to close the gap in between through which the direct can
lower
pass
lip,
through.
between the lower lip and the conjoint tendon.
Yeah.
Lower lip of the inguinal ligament and the conjoint tendon. But even then, it will cause tension because the defect size is very big. You have to approximate that. So if you bring a conjoint tendon and the inguinal ligament, that will cause a lot of tension. So any solution for that to release this tension?
In the rectus sheath, we could also do an curvilinear incision to release the tension on the conjoint tendon. So it will.
What's that called?
There's less. Where ones?
Tanner slide. Tanner slide.
Tanner sliding. Yeah.
Tanner sliding incision. Okay. You just release the lateral part of the rectus sheath also. So that is a part of the conjoint tendon. So the conjoint tendon comes down, slides down. Yeah. So it gets more approximated with the inguinal ligament. Okay. What is Popper's ligament?
It's also the inguinal, other name for inguinal.
Okay, it's an MCQ. Okay, that's an MCQ. Okay. What is Gimbernat's ligament?
That's the lacunar ligament.
What's Cooper's ligament?
Extension. Huh?
What's Cooper's ligament?
Cooper's ligament is the iliopubic tract, which is a continuation of the lacunar ligament on the pubis and the
ilium. Okay, good. So all these things you should know. Other names also for MCQs. Okay, they always ask the other names. Okay, so what is Lytle's repair? Larry, one interesting question. You told it's a irreducible hernia, right? Yes. Left side is irreducible hernia. After opening the inguinal canal, you need to anyway push the contents inside, right? You need to reduce the contents. Whatever, if it's a momentum, you can excise. Okay, if it is a bowel and all, you need to put it inside. But it's not going because the ring is very sac or the ring is very narrow, so contents are not going inside. What do you do?
Maybe relaxing incisions on the deep ring, and after you put it back in.
What is that called? Huh? What is that called? Okay, if you are putting incision, where you will put the incision?
Since it's in the deep ring, which is found by.
Think.
Radially.
Either you'll put medially or laterally. Lateral to the deep ring you'll put, or medial to the deep ring you'll put.
Lateral, because medial, if you cut it again, then there's a chance of weakness.
No, not weakness. What is there? What important structure is there? Medial to the deep ring.
Oh, medial. There's a inferior epigastric artery.
Very good. So you'll put the incision laterally, and then when the ring becomes widened, then you put all the contents inside. Then you can, or if the ring becomes very big, then you can repair it. That's called Lytle's repair. Lytle's repair. If in any case, if the deep ring is very big, then you can make it small by using Lytle's repair. Okay, then you can do the herniorrhaphy and then the hernioplasty. There is no confusion between herniorrhaphy, and hernioplasty. There are so many types of hernia repairs are there. Study all theory, Bassini, Scholdi's, Mbbs, so many, Desarda, so many things are there. Even the hernioplasties also, like stents, topas, this, that, some laparoscopic, there are so many things. At least UGs, you should know at least to name the laparoscopic approaches, if not everything. What are the two approaches in laparoscopic hernia repair?
Transabdominal preperitoneal and totally extra preperitoneal
Tap and
repair.
tap. Okay. Tap and tap. Okay. These are the two approaches. So then some questions can be asked about the laparoscopic hernia surgery also. You should know theory at least. Some favorite questions are like what is space of Ritzius, what is space of Bobros, what is triangle of pain, what is triangle of doom, what is circle of death. Okay. Okay. These are all the more very common questions, favorite questions. Okay. What are the contents of the triangle of pain, other things. Okay. So these are the 5-6 questions, favorite questions, laparoscopic hernia surgery. Please read about that, the theory part. Okay. Then usually, Larry, the indirect hernias are the congenital ones, or it could be sometimes it could be acquired because the process vaginal is almost obliterated. But even due to some precipitating factor later on, it may get open up or become a sac and they form indirect hernia. But direct hernias are always acquired.
Yes.
Right? Because of the post-mortem weakness, it's a acquired hernias only. But one exception is there. That is Ogilvie's hernia. What is Ogilvie's hernia?
Which hernia?
Ogilvie's, Ogilvi, Ogilvie's hernia.
Ogilvie's into the pouch of Douglas?
No.
Yes.
That is a defect in the conjoint tendon. The hernia
medial
through the medial part of the conjoint tendon. If it comes out, then it's called Ogilvie's hernia. It's a type of congenital type of direct hernia. Okay, you should know. Okay, then what is sliding hernia? Why I am asking because in this patient it could be a sliding hernia.
Yeah.
Okay, because elderly patient comes with the indirect hernia. Okay, that too you are telling it's neither it is a omentum nor it's intestine, that kind. Okay, so most probably it's a sliding hernia what you have got, and it doesn't go obstruction. Most of the time these sliding hernias are irreducible but not obstructive. Okay, see, he had it for some 4 years. Okay, for last 4 years. So it could be mostly a sliding hernia. So what is sliding hernia?
The posterior wall of the hernia is formed by the viscous, like bladder or bowel.
Bowel, like on the right side, it could be cecum. On the left side, it could be
sigmoid colon.
Sigmoid colon. Okay, elderly, this is common. Okay, very common. So this is sliding hernia. What is saddle hernia? What is saddle hernia, double hernia, or Romberg's hernia? You just now told. You have answered it already, but these are the other names, MCQs for it.
Saddles may be both pantaloons hernia, other name for pantaloon.
Yeah, exactly. You know the things, but you are a bit hesitant. Okay, it's also another name for pantaloons hernia. There are 4 names: pantaloons hernia, saddle hernia, double hernia, or it's also called Romberg's hernia. Okay, if you know 3 and not 1, then gone. Okay, they must the 4th one. Okay, so you should know all possible names and this thing. Now, one of the, what is metastatic emphysema of Reed? They say this is the cause for acquired hernias. You read the concept of metastatic emphysema of REED, Reeds. Okay? You read, this is the theory behind any acquisition, what is acquiring hernia. It's a good concept. You should read. Okay? And what are the possible complications in hernia surgery?
Surgery, there could be hemorrhage because of superficial epigastrics and circumflex and superficial pudendal. There could be injury to the cord structures, like what everything in the spermatic cord or iliacal nerve, which will cause hypoesthesia around the root of the scrotum.
Epigastric and all will not come there. Okay. Mainly in the inguinal canal, what you get is inferior epigastric artery and then the lower down femoral artery. Only those two vessels can be get injured. Okay. Then the cord structures. Okay. Cord structures. Then
around injury to the bowel, which we are trying to reduce. Okay. It could cause like perforation or some.
Okay. Then okay, immediate intra-op, immediate post-op, sorry.
Immediate post-op, there could seroma, hematomas, infection of the hematoma, which could cause dissolving of the mesh, or urinary obstruction because of handling the bowel, or
then what is inguinodynia?
If there is any traction to the nerve, or if the nerve gets entrapped in the mesh, iliohypogastric or iliohypogastric more likely to be. If it gets entrapped in the mesh, it could cause pain, and if there was traction while suturing, or if there was any neuroma formation after cutting the nerve.
Yeah, very good. So ideally, you should try to preserve all these nerves and structures. In case you are not able to, then cut with the scissors. It's called scissors. Yeah. Don't use cautery and all, because high chance of forming neuroma or the nerve and that irritation. Okay. So if the nerve is cut, then what will happen? In the inguinal canal, if the nerve is cut, then what is going to happen?
There won't be any hernia, direct hernia as a result of the injury, but there will be hypoesthesia in the root of the
sensation in the root of the scrotum or penis and that area. Okay, so sensory part is lost, but motor is intact because it supplies the muscle before entering the inguinal canal. So if any surgeries or any injury to the nerves in the inguinal canal will not cause any motor deficits or the weakness of the muscles, only the sensory weakness. Okay, any other complications long term?
Any
long-term complications?
Meshomas.
Okay. Then
incisional hernia.
Okay, if the anterior-abdominal wall is very weak. Okay. Then like in your case, what can happen?
In
your case, what can happen? What's the complication in your case? Recurrence. Right? Recurrence also a complication, right?
Recurrence, yeah.
Okay, so recurrence also a complication. So, okay, now how do you follow up this patient?
Okay, so
advice at the time of discharge to this patient?
Usually the mesh starts getting fibrous. That aseptic inflammation starts around the 7th day, and it usually completes by 1 month. So like we ask the patient to like not do any strenuous work at least for 6 weeks, or if it is heavier work, maybe even for 3 months or more.
Then usually the most common, what we suggest is, if any swelling is there, immediately, okay, after surgery, after a few days, immediately come back to the surgeon, because most commonly there will be collection after hernia surgery. Seroma collection is very common. Okay, so if any collection, any swelling recurs, to come back immediately, we have to drain the seroma. Okay, if minimal is there, you can just put a tight bandage and leave. If a lot of collection is there, you have to ideally drain or aspirate. Okay, because if it stays, it can get infected and cause wound infections. If the mesh gets infected, what will do, Larry?
We'll have to remove the mesh itself.
Antibiotic you'll give?
No, like since the mesh doesn't have any blood supply, there's no point in giving antibiotics. So we'll have to remove the mesh itself.
Very good.
And then do a hernia raphy after removing the mesh.
Okay. Okay. Oh, okay. In case if it was an obstructed hernia, what you would have done?
There again, we wouldn't put a mesh because there's a chance of infection again. So again, a herniorrhaphy.
Any approach it will change in obstructed hernia?
Approach. Higher approach like Mbbs.
Do you prefer higher approach or lower approach in obstructed hernia? Big inguinal scrotal obstructed hernia is there. You should put the incision lower down. It's not just inguinal incision. You should put a lower inguinal scrotal incision. Wherever that the contents are there, over that you have to put. Okay. Then see the contents. If they're viable, okay, then just slowly reduce the contents. If they're not viable, okay, if they're gangrenous bowel and all that, then do the resection anastomosis and then push the contents inside and do the just a roughy. In that setup, herniorrhaphy and leave. Then later on, after 1 or 2 months, you can do the definitive hernioplasty. Okay. What is reducing or NMAS reduction?
NMAS reduction. Make maybe the entire content through a small through a larger hole, like you put, like we put it back into the abdomen, like at the same time.
Okay, yeah,
I'm not sure,
but along with that constricting part, okay, you are pushing the entire content into the abdomen along with the constricting part. What my point?
Okay, yeah.
What my point? That the site of obstruction is not relieved. Site of obstruction is not relieved. Instead, you are directly pushing everything inside the abdominal cavity as it is. Later on, it can cause, it can precipitate the obstruction. Also, otherwise, if the subacute obstruction is there, it can result in stricture and all in later part. So, okay. So, in like case like yours, irreducible hernia, obstructed hernia, we should not forcibly try to reduce the contents. Okay. Give proper analgesics and slowly try to do the taxis or the manual reduction of the hernial content. If not going, don't force the force it. Okay, leave it. Then you can do the emergency hernia surgery. Okay, same in case of the what you will do in the strangulated hernia.
If we check for the bowel, if it is necrotic or not, like based on the
first stabilize the patient. First stabilize the patient. Most important. Patient will be very toxic and okay, all the septic features will be there. Stabilize. The BP hypotension will be there. Okay, all those things you stabilize. Then immediately go for the surgery. Okay, again here also we should put the incision in the more dependent area because that toxic fluid collection and all will be there. So put a inguinal scrotal incision. Open this thing. All the toxic. Just immediately suck out all the toxic fluid and all. Don't let it enter the abdominal cavity, which may cause inflammation there of peritonitis and also. Okay, suck out. And if the bowel is viable, how will you check for the viability of the bowel?
The best way is to give 100% oxygen and check for the changes, but other could be like color changes and peristalsis. Like if it's a darker bowel or if there's no peristalsis, it could be the bowel is not viable. But best would be to give 100% oxygen to the patient and check for the reappearance of
warm saline mop you can keep.
Warm saline
mop you can keep for some time. Okay, then look for the color change. If that lusterless, dark colored bowel gains back the normal color, then it's viable. If not, then it is already gangrenous. You can do the resection of that gangrenous part and do the anastomosis of the remaining part. Okay, this is for the strangulated hernia. So any in elderly male, okay, it is a reducible hernia, both sides reducible hernia, and patient is not fit for surgery or not willing for surgery. What do you do?
That time we can try conservatively, like with the truss, like which is like hard covering around the groin region, which will prevent the hernia from coming back out.
Okay. One more application of knowledge. You have opened the inguinal canal. So where you will look for, Larry? Where you look for the sac?
In between the external oblique and the
external oblique you have opened. Okay, now you can see the the cord and the what will be there in the inguinal canal? What all will be there?
One will be the spermatic cord and the ilioinguinal nerve, and in case of females, round ligament too.
Okay, and it will be attached to with the, or it will be just underneath the muscle, premastic muscle, right?
Okay. Yeah.
Okay, and the conjoint tendon above. So you have to separate the cord from the muscles. Okay, in the cord, what is the relationship with the sac and the cord? I'm asking you.
In case of the indirect hernia, since processus vaginalis is within the spermatic cord, the indirect hernia also goes through the processus vaginalis, so it should be within the cord.
It will be usually anterolateral, the anterior to the cord. So anterolateral. So whereas the direct hernia, you find the sac
posterior medial.
Posterior-medially. Okay, this is how the relationship with the cord and the sac. Okay, good, nice. You answered almost everything. I don't have anything left. Okay. This is the basics. Okay, basics of the there are other hernia surgeries. All can be asked, but almost all the basics questions you have answered very well and correctly. So yeah, read about that laparoscopic approaches and whatever that anatomy I have told you. Okay, and complications properly. Okay, it should be in your fingertips. You should not think during the examination. Okay, anything, any complication, tell intraoperative, immediate pre or post-operative, and late post-operative, like that. Classify and tell. Okay, and any doubts?
In Bailey, it's given that if it's a small hernia, we could try to like conservatively manage by painkillers. Is it actually like?
Yeah. If it's asymptomatic small hernias, no need to operate. Okay, all the hernias need not operate. Okay, what is occult hernia?
Occult, it cannot be found by examination. It's only by an investigation like MRI.
Okay, or a patient will be always complaining of pain in that area, inguinal region.
Yeah, pain.
But the hernia will be, it may be just what is that, pre-hernia, symptom. Okay, just before the hernia also, he can have just pain, or even the hernia may not be manifesting, only he'll be having the pain in that area. That is occult hernia. Okay, what is sportsman's hernia?
Sportsman's hernia is again a minor tear which causes the colon to get entrapped in between the muscle fibers, which causes pain.
Not the colon actually. This whatever the ligament tear has happened. Okay, ligament tear, that only bulges out and gives you a false impression of the swelling. Okay, of a hernia. It's called sportsman's hernia, and there are so many named hernias that you should remember. No, Larry. They'll ask you what is Richter's hernia, Lichter's hernia, depending on the contents. Okay, this is another set of questions. All the named hernias you should know. Okay, so